Everyone. Good evening. Good evening in India. It's morning here. It's good to be among Indian colleagues. I haven't been home for a long time, so this feels like I'm there a little bit anyway. I've been charged to talk about the topic of the right choice of the pacemaker in an 80-year-old female with a complete heart block, haemodialysis, a left-sided AV fistula, and a right-sided occluded vein. I have to defend the strategy that the leadless pacemaker is the most suited option. In the next 10 minutes, I would like to talk about the issues with traditional transvenous pacemakers in this setting. I would also like to talk about the advantages of leadless pacemakers and also present potential arguments that are against leadless pacemakers and try to defend these arguments. For those of you who may not be aware of the leadless pacemaker technology, this is really amazing and probably the future of cardiac pacing. There's no leads, there's no pacemaker pocket. The most commonly used system is the Micra Medtronic system. This is a time-based pacemaker that is implanted from the femoral vein. We put it in the right ventricular septum in the trabeculae. Once we feel it's in a good location, we tug on it and then we remove this string attachment, and the pacemaker is left in place. Again, no leads, no pocket. This is a relatively newer system that is not being used as much. The first version had some issues and now they have come up with a newer version. This is the Abbott system. Instead of the tine or the passive fixation mechanism, this is an actual screw-in mechanism. The advantage of this is it has a longer battery life and it can also be retrieved many years later if needed. In terms of issues in ESRD patients, if you put in a traditional transvenous pacemaker, I think the biggest issue is infection, whether it's endocarditis or pocket infection. We are a large extraction center, and so we get a lot of referrals for these patients. Even at this time in the hospital, we have 2 patients with end-stage renal disease that have infection, both with MRSA. We did 1 extraction yesterday, very sick patient, and we have actually 1 coming up that has a large SVC mass with MRSA bacteremia that we have to first do an angiovac and remove that mass and then do the extraction. These are very high risk procedures, and I'll also try to share some data on how these patients do and how they get there. There is actually a risk score to calculate the risk of infection when someone undergoes a traditional transvenous pacemaker, whether it's pocket or endocarditis. And you can see in the middle that renal dysfunction is actually one of the factors that increases the risk. In this a study from the US, more than 500,000 patients with were studied. There were 6% patients among these ESRD patients that had some form of a pacemaker or ICD, transvenous, not leadless. And among these, the rate of infection was 8%. That's like 1 in 10. That's obviously a very high risk. Only 1 in 3 of these patients underwent extraction. And even if they did undergo extraction, the outcomes are not good. 16 months versus 9 months. Again, if these patients get infected, they don't do well. This is another study from the Cleveland Clinic that looked at 1,400 patients undergoing extraction, and they looked at patients that had normal renal function and those that had renal dysfunction, either on dialysis or not on dialysis. For the sake of this presentation, I'm just comparing those on dialysis and those with normal renal function. You can see that the risk of complications is double, 7% versus 12%, and the risk of mortality is almost 4 times 6-month mortality in those that had normal renal function versus those that were on dialysis. Again, when these patients get infected or have vascular issues and need extraction, they don't do well. I don't know if anyone else has seen this issue. We are again an extraction center, so we get a lot of referrals for this. I like to call this the Hemi-Hulk syndrome. The story typically is a patient has a fistula on one side and then they need a pacemaker, so they get a pacemaker on the other side. Then something goes wrong with this fistula, So they put a fistula on the same side as the pacemaker, and now there's all this fibrous tissue and growth around the leads. The vein is occluded, and now the arterialized vein flow cannot get back to the central circulation, and so the arm and the upper body start swelling. These patients usually have a lot of pain and discomfort, and we have had to perform extraction in an arterialized venous system again, which is very high risk of bleeding. Leadless pacemakers, on the other hand, it's obvious because there's no leads, there's no vascular issues, but it's also a much lower risk of infection, both the pocket infection and endocarditis. But why is that, right? It's a foreign body, so why is there so much less infection with leadless pacemakers? For one, there is no pocket, right? So that's the best part. So one part of the infection is the pocket infection, and that's completely taken out if there's no pocket. But the other is also the risk of endocarditis, and the key word is forming a biofilm. Because of having almost 1/7 of the surface area, and a lot of the pacemakers actually get completely encapsulated by biological tissue. I'm sorry, there's some issue here. Are you still able to see my slides? Okay.
Yeah, we are seeing your slides. Yeah.
Okay, thanks. Because it gets encapsulated by tissue, the chance of forming a biofilm decreases a lot. These leadless pacemakers also have a parallel coating that prevents biofilm formation. This coating is not there on the traditional transvenous pacemakers, and also it is implanted, at least as of now, in this turbulent right ventricle, right, where there's so much flow that the chance of forming an actual vegetation is low. I'm sure a lot of you do transesophageal echocardiograms, and if you all have seen any fibrous tissue on the pacemaker leads or ICD leads, it's usually in the right atrial aspect. It's very rarely in the right ventricular aspect because of this reason. There are some arguments against leadless pacemaker that I'll try to go through. One is safety, that the risk of pericardial effusion may be slightly higher. If there is a pericardial effusion, then the risk of cardiac surgery is higher. Again, this was the initial experience. Things have changed now. There's obviously cost considerations. There is an upfront cost with the leadless pacemaker, but I think it pays off in the long term, especially in the population of end-stage renal disease. There is this possibility of AV dysynchrony and pacing-induced cardiomyopathy, which again can only be truly solved by either a dual chamber pacemaker for AV block and AV dysynchrony, and CRT or a conduction system pacemaker for pacing-induced cardiomyopathy. And I will present a slide on that to show why a leadless pacemaker may not be such a bad option for that. Extraction risks, again, once this leadless pacemaker goes in, especially the time-based system, extracting it after 6 months to a year is hard, but do we really need to care about that in this population? That's also another point I'll try to talk about. In terms of safety, this was actually studied, in the Medicare population, which is more than 65 years old in the US. They compared patients undergoing single chamber pacemaker implants, whether leadless or the one with a lead, and they compared 6,000 patients versus 10,000 patients. 12% of the patients with leadless pacemakers were on dialysis versus 2.3%. Again, this is not a randomized trial, it's an observational study, but this reflects the practice patterns and the concerns that physicians have in putting traditional transvenous pacemakers in patients on dialysis. Also, the patients were more frail and had a higher frailty index when they had a leadless pacemaker implanted as opposed to a more traditional transvenous pacemaker. And the outcomes were actually a lot in favor of leadless pacemakers. When you look at re-intervention, whether it is revision or replacement or upgrades, it was 2.7% in the leadless pacemaker group and 4.9% in a traditional transvenous pacemaker. And again, this was mainly related to problems with the lead and the pocket, not so much upgrades. Overall upgrade rate in both groups were very low. As it relates to complications, it was again lower in the leadless pacemaker group as opposed to the traditional transvenous group, 4.6% versus 6.5%. And again, this was mostly related to lead issues, infection, and pocket issues. There was not much difference in mortality. It was very similar. We adjusted 2-year all-cause mortality. So we are looking at, a high-risk population now that is probably going to live the same amount of time with either a leadless or a transvenous pacemaker, but with less complications, less reinterventions, and probably a better quality of life on account of that. We are very focused on safety, and I won't spend too much time on this, but we use some fluoroscopic techniques to confirm that this is the RAO space sign that we described in 2021 to make sure we are on the true septum. We are also strong believers in the use of echo. LAO may not tell the true story. LAO may tell us that we are septal, but we may still be on the free wall, and we are strong believers in using echo to readjust the position to make sure we are on the true septum to avoid perforation. Costs have also been a concern, and this was a French health study that looked at patients in 2015 that could have been candidates for a leadless pacemaker. Those that are undergoing single chamber pacemaker or more than 80 years old with dual chamber, or those with CRTP implants greater than 90 years old. We looked at the cost of these complications that happened in these patients. 5.3% risk of complications, mostly lead and pocket complications. Again, it was in France, so it's in euros, but again, a staggering cost, as you can see from the slide. And this I found very interesting, actually. I found a study where they looked at the cost in Poland of a patient that was actually quite similar to the patient in question. She was 80 years old, end-stage renal disease, on warfarin, that required a generator change, a very high risk of infection, obviously, and they ended up doing a generator change to save costs, but she ended up having an infection, multiple hospitalizations, finally had to undergo a high-risk extraction and then leadless pacemaker implantation. And they compared if they had done a leadless pacemaker up front, what would the cost difference be? And you can see that the cost difference is almost double. In terms of AV synchrony, again, in the era of when we only had pacemakers with leads in 1998, they actually looked at the pacing mode in patients with dual chamber pacemaker. And if you did DDD pacing, which is AV synchronous pacing, versus VVI pacing, there was actually no difference in the quality of life in patients with AV block, in patients that were more than 65 years old. And looking at cardiomyopathy from pacing, again, this was a recent study that compared transvenous versus leadless pacemaker. Maybe because we put the leadless pacemaker on the septum as opposed to the apex, which we often do with the transvenous pacemaker. I think we are a lot more careful with the leadless pacemaker to make sure we are on the septum. Maybe because of that, the risk of cardiomyopathy is lower, because on the septum we may have a slightly more synchronous contraction than when we are on the apex or the free wall. And does extracting leadless pacemakers matter in an 80-year-old? The battery life is 10 to 24 years. The risk of infection is very low. In a lot of patients, these are destination devices that get them through, hopefully with a good quality of life. So in conclusion, transvenous devices and ESRDs are very high risk of infection and vascular issues. When we have to extract devices, here the risks of extraction are high, so we have to try to avoid leads in these patients if possible. Leadless pacemakers, on the other hand, very low risk of infection, no vascular issues, and it can be a safe and cost-effective strategy that can improve quality of life. And again, I am going to date myself to when I was in India in the 90s, but as my favorite actor would say in my favorite ad, that in this situation, the leadless pacemaker is the right choice. Thank you.
A very good evening. Thanks, Dr. Kanu Sharma, for having me here to speak on this topic. And respected chairpersons, dear colleagues, I would present my side of the story. However, I would thank Dr. Temi to have had this initial conversation regarding the leadless. So my point would be very clear. So you have this kind of case, or in an 80-year-old, you need to know so many other things like the weight, comorbidities, family status, and the acceptability. And you need to know whether the complete heart block has to be treated in an immediate or a planned basis, and whether this fistula that is there, what is the frequency of dialysis, what is the degree of renal dysfunction and present health regarding the same. Regarding the occlusion on the right side, you need to know whether it is external occlusion or it's due to fibrosis because of prior intervention, and what is the imaging technique used for that kind of diagnosis of a occlusion. And lastly, to know the ejection fraction at the time, we were not provided with that. However, I would say at the onset that there has to be no debate as such, because the topics that have been given are whether leadless pacemaker is best suited. Yes, it is best suited. However, from my side, I would say that venoplasty and endocardial pacing is cost effective, and that is what I am here to say. So, going on to venous occlusions, we know that venous occlusions are not uncommon, and complete occlusion are there in around 2 to 6% of patients of the overall occlusion rates. However, if they had a prior intervention, definitely the rates are very high. They may be asymptomatic because of collateral circulation, and fibrosis or thrombosis are the most common causes. Venography prior to implantation is very important, rather than relying on a CT image or a sonographic image, and that's very important. So my outline would be to see how to approach these patients. What are the alternatives for pacing in patients with hemodialysis, excluding the leadless, as has been discussed? What is the approach to do a pacemaker after venoplasty, and comparing it with a leadless pacemaker. So, as seen in this table, in patients who need a pacemaker or a device for that matter, you need to answer two more questions: whether the patient has a future access for hemodialysis, or peritoneal dialysis option is there along with kidney transplant. In a elderly, obviously transplantation may not be there, but an option of a peritoneal dialysis may still be there. Then going on to venography, whether it is a stenotic lesion in which there is some flow, or it is completely occluded, and if it is open, then definitely a venoplasty is as easy, in which a direct wiring can be done and a lead implantation is very easy. However, if it is an occluded, then comes the problem of doing a further intervention in which you need a balloon support or a venoplasty from either the antegrade approach or the femoral approach. And other options like getting the external jugular or a supraclavicular approach for subclavian vein can be considered. Rarely femoral or iliac access can be considered. And if you don't have a leadless pacemaker, an epicardial lead as a bailout can be considered. So alternatives is what I am going to discuss rather than just a venoplasty, and these are the three major. So ipsilateral implantation of pacing lead where you have an existing AV fistula is possible, though it increases the risk of bleeding, the risk of infection, as well as the stenosis, and as shown by the Dr. Tanid, the hemi-hulk as he calls, can also be there because of the stenosis. But how can you still do it? You can do it safely if you have a cephalic access. Least number of leads that you use smaller, fine leads, you use a smaller device, don't make a large pocket, make the pocket lower down. And to prevent further stenosis, or in fact intervene before the stenosis is complete, you need to do a regular evaluation of patency by venograms, and especially do a venoplasty if stenosis is detected before the occlusion occurs. So this was a study which showed that secondary interventions in patients with implantable cardiac devices and ipsilateral atriovenous access is not as bad, though the interventions are much earlier, but the rate of intervention is similar and the failure rate and infection rate were negligible in this study, showing that in patients in whom you have no other choice, you actually can do an ipsilateral side access also. Transjugular is not commonly used, but it may actually be a very useful alternative in elderly, though it has the problem of having the lead being superficial because you have to tunnel it through. However, it is an excellent alternative. These are out of the blue, out of the box thinking, in which you use a long lead with femoral access or a transhepatic access, which we would normally not do. So coming to the core topic of contralateral implantation with or without venoplasty, and first and foremost, you need to do a venogram. If you see in adduction, you get a good flow, but in abduction, there is an apparent stenosis. Also, when you do a venogram, you should be clear that there is no spasm. Sometimes it is seen, and you give NTG, you would find that it is a good vein. So it is good to do a NTG if you find some kind of narrowing. Sometimes cephalic access, in fact, we know this patients with ESRD, cephalic vein, if it is prominent, it may be of great use. Even in a normal situation, you can use that so as to prevent stenosis at the site of punctures. But the cephalic vein can join after the stenotic line, or it can go supraclavicular itself from the stenosis area and provide you a good access to go through the cephalic vein and access to the RV to pace. Intrathoracic punctures, that is puncturing proximal to the block, wherein you do an intrathoracic pec puncture, but it has its own sets of risks, so you have to be careful. So the most commonly used would be a venoplasty or progressive dilatation using dilator. So you do an antegrade puncture, and once you have access to the vein, you pass in a wire. Mostly it is useful for stenotic lesions rather than occluded lesion. You do a progressive dilatation with increased size of dilators, pass the sheath and position the lead. The advantage is no additional hardware except dilators, minimal cost, least amount of intervention, and the patient goes home as if the pacemaker is done in a normal person. The disadvantage is, or you should remember, is you cannot remove the sheath until the lead is fixed. Once the dilator is removed, it's difficult to manipulate as the sheath may kink. And it is very important to understand it doesn't make the vein patent. The vein is still blocked, and multiple leads cannot be accommodated. So it's generally referred only for a single chamber. What about venoplasty? The advantage is it opens up the vessel and possibly maintains the patency later on also, improves symptomatology if the patient was symptomatic, easier implantation if especially multiple leads have to be implanted. The disadvantages being additional hardware like balloons especially are used and increases the cost. So antegrade only technique in which you just access from the subclavian area and you can just dilate and then complete the procedure, in which you do a balloon angioplasty with or without a stent. Both antegrade and retrograde is generally reserved for patients who have an occlusive disease, long segment or central occlusion, in which you have to do a femoral as well as a subclavian angio and then get the bridge through a wire. Now, most of them would be a PTCA wire, and all PTCA techniques should be used for these patients. Progressive dilatation with balloons and additional stiff wire along with balloon dilatation can be used. You may use help of a snare also. Stenting is reserved in patients who have acute occlusion or with recall dissection or long stenosis, central stenosis or recurrent stenosis after balloons. Choice can be self-expanding or a balloon expandable stent. So here is one of the largest series by Worley et al., where they had shown that over 11 years, and that too, this was published in 2010. So after which the hardware has improved drastically, they have shown that most of the patients, they could do venoplasty. That is only 371 of 373 patients venoplasty could be done, and nearly no life-threatening complications with good success. No near-time infection was seen in these patients, and they could complete the desired procedure well. And they have given a list. They have given 22 steps how to do easily. And it's a very good paper to see how to do a venoplasty in patients who have CIEDs. So what they have said is a peripheral vein venography, contrast injection is the best. You do see a better result with a venoplasty rather than dilators. It preserves venous access, and that's very important. You don't leave a closed vein. That's very important for the patient. It also, once you go step by step, you will be actually much better off doing these cases. So what are the pacing points that you should remember? Single chamber pacemaker is preferred. Smaller lead and sheath size is preferred. Double wire always to be given. Remove wire once the lead is positioned. Do not remove the sheath till the lead position is acceptable. Always use a long battery life pacemaker. Hemostasis should be proper, and antibiotic to prevent infection is very important. So comparing technically venoplasty versus a leadless pacemaker, the venoplasty treats venous occlusion as well as the related symptoms if they are there. It is the only way that you can do an AICD or a CRT rather than with a leadless. A single site access is generally used. No special training or support is required as what we need for a leadless pacemaker here in India. And it can be done emergently. You don't need the person to come the next day or the next within 2 days. Successful nearly in always, and complications are easy to manage as compared to some dangerous complications in a leadless pacemaker patient. And a long battery life devices can be used, and PG change is easy if required later on. Most important is cost effectiveness in the Indian scenario, where a venoplasty and a pacemaker implantation can be done as cheap as 1.3 lakhs to the maximum, including a stent, to be around 2.5 lakhs. And then a PG change cost, if the patient is there for a long term, is minimal, and that is best for the Indian setup, while a leadless pacemaker cost here itself is around 7.5 to 8.5 lakhs, with implantation can go up to 12 lakhs. And recurrent cost of a new device at battery depletion is important. But yes, it is best for Western or reimbursement setup. Leadless pacemaker is not without complication, and as you can see, these are the complications. I would not enumerate them. But leadless pacemaker implantation in hemodialysis patients, the experience with Micra, as in this paper, showed that 98% though were successful, there were 2% mortalities. However, there were no infection as described. So these are the things that you need to remember. Embolization you need to retrieve. There may be a vegetation even on a leadless pacemaker, though not seen very commonly, and vascular complications because of a large sheet. So summarizing, venoplasty with a standard pacemaker implantation is most cost effective, especially in a stenotic lesion, as described in this case. The Indian case scenario says that this is the most cost effective strategy rather than going into the costly leadless pacemaker of our times. Thank you.